أنس عبر في ساعة. بسم الله الرحمن الرحيم. ايه ما بدينا. الساعة اللي عندي 12:48. هذول كل الريزدنتس ولا 12 13؟ اعذروني اليوم عشان الصوت بس. We'll talk about mainly on conjunctival tumors as well as anterior segment. When we say anterior segment, mainly iris in addition to the conjunctiva. It's very important to know what is the most common conjunctival tumor as benign or malignant, as well as the most common conjunctival epithelial tumor, and also the behavior of the conjunctival tumors. شكرا ناس. Okay. And the factors that determine recurrences. When we say recurrences, mainly we'll talk about conjunctival squamous cell, or what has been renamed now after CIN to be OSSN, which is ocular surface squamous neoplasia. And then the iris inclusion cysts, which is important because they are more aggressive. We know from previous studies that the benign tumors represent about 60 or 61%. This is by yearly statistics until 2006, and from the registry that was done at King Khalid Eye Specialist Hospital, and you can see starting from 1983 only 13 cases to 2006, which is 72, and the most common one was retinoblastoma. For the most common one that has been submitted for surgery in the anterior segment is squamous cell carcinoma, or CIN or OSSN. However, the most common one, benign tumor, is nevi of the conjunctiva. This can be classified into four: congenital, vascular, epithelial, and pigmented. And the most important one also is epithelial, and the most common ones that need surgery. The congenital, as you know, is mostly dermoid and dermolipoma, which is a cholestoma, where there are structures that are not normally present in the tissue itself. Location-wise, it is most commonly present in the temporal, and can be epibulbar, and can be even 360 degrees, and can be attached to the conjunctiva, to the skin. And this can be also inherited or solitary. And what contains is skin appendages, such as sweat glands, hair follicles, and so on. This is an example of a very peripheral, small dermoid that is present at the peripheral part of the cornea or the limbus. And their treatment is extremely easy. You can leave it alone if it doesn't cause any astigmatism, or you can shave it, or remove it and put lamellar keratoplasty. lamellar keratoplasty corneal tissue so that it will hide the opacification. And it is mainly removed as cosmetic reason. Dermolipoma, where fat is prominent and there is no cutaneous structures. And it is associated with syndromes such as golden heart syndrome. These are another examples of dermoid with skin attachment, as well as also ectopic lacrimal gland and dermolipoma, as you can see on your right. So all of these are colistomas. And this can be, the ectopic lacrimal gland can be simple or complex colistoma. And it may also extend or isolate it to the cornea. For the vascular tumors, you can see from their look that they are heavily vascularized, tend to bleed, and abnormal dilatations of blood vessels, and may cause prolonged irritation. They can be also associated with thyroid ophthalmopathy. There are also telangiectasia associated with some brain problems, and these can sometimes be inherited as autosomal dominant. Biogenic granuloma, as you can see in here, is also another vascular growth that is commonly seen following trauma, surgery, and can be anywhere in the conjunctiva, in the cornea, or in the lid. And these are examples. Sometimes they are sessile or pedunculated, as you can see. On your left is it is sessile and pedunculated, and it forms of dilated blood vessels and easily bleed, and they can be easily also removed. Some of them, they even can be disappear with topical steroids for over 3 or 4 weeks. These are some telangiectasis present in the lower palpebral conjunctiva. It can be left alone or it can be even removed. As I mentioned, this can be also inherited with other syndromes. And capillary hemangioma can be coming as alone or associated with orbital hemangiomas, and present early in life and may grow rapidly and regress spontaneously before 5 years of age. Again, the treatment can be conservative by leaving them alone, or if cosmesis is needed, you can even remove them. Some people even inject some steroids to remove them. This is an example that was managed by Dr. Huda Al-Ghadir and myself a long time ago. With capillary hemangioma, it can be easily removed and completely excised with an excellent cosmetic appearance. Cavernous hemangioma is deeper in location and it is less frequent. Again, also conservative treatment. Lymphangioma is always confusing because they may present to you as inflammation or chemotic conjunctiva. So you will see some swelling of the conjunctiva. And they are slowly progressive and can involve also the orbit. And if there is any spontaneous hemorrhage, it may leave you with a chocolate cyst, black cyst. Lymphangiectasis is extremely common and easily overlooked and not easily diagnosed. And these are just lymphatic blood vessels present in the conjunctiva. They can they can appear in one area, disappear in another area. They need nothing. They just need reassurance for the patients, because even if you remove them, they will recur to another place. So there isn't any reason for you to remove them. If patients insist, sometimes you can remove them, but they are not needed. These are lymphomas. You can see the pictures, and you can see even the lymphangiectases, which are vessels or channels that are filled with a clear fluid, which is lymphatics. And these are the other pictures of lymphomas you can see in here. For epithelial inclusion cysts, they follow a trauma or surgery, most commonly strabismus, sometimes retinal surgery, but even after glaucoma procedure, sometimes if you have some epithelial cells that has been taken under the conjunctiva, they might grow as a solid, and with a cavity and with the secretions of these conjunctival cells, they will have translucent fluid. If some of these cells that has been implanted under the conjunctival surface are from mucin secreting cells, the fluid will appear turbid and milky because of the mucin. These are examples of different patients. This is following a trauma. This is following a trauma as well as glaucoma procedures. A huge conjunctival cyst, sometimes even linked to the anterior chamber. This is a very interesting patient who has Ehlers-Danlos syndrome, and as you know, Ehlers-Danlos syndrome, they have extremely thin cornea, and the treatment before, we used to tamponade or strengthen the cornea by having a very large kerato patch, which is 12 millimeter from limbus to limbus. And if because of this, because they are mainly done for children, epithelial cells are active, so you might have epithelial cells that has been taken under the graft. And this is what happened in this case. Patient developed epithelial cell cysts, and you can see this is the host cornea, and this is the kerato patch, and you can see with the fluid level, there is another area here. This was managed by removing the kerato patch and cleaning the epithelium, and sometimes you soak it with alcohol to kill the epithelial cells, and you can put another kerato patch or you can leave it as it is. Another benign hyperplasia, which is called pseudoepitheliomatous hyperplasia, and this is sometimes confused with squamous cell carcinoma of the conjunctiva. And develops, it takes sometimes weeks or months, and it is just hyperkeratotic surface with central amplification. So the central part you might have amplificated. It can be present in the skin over the lids or on the conjunctiva, and they sometimes appear as white and should be differentiated from squamous cell carcinoma. These are pictures that were taken from another reference. This is pseudoepitheliomatous hyperplasia. They appear mostly white because of keratin present on the surface, and they just can be treated by excision, or you can leave them as it is. You might have some inflammation with the lymphocytic infiltration in these cases. The distinction between it and squamous cell carcinoma, the conjunctiva, that there is a transition zone into normal epithelium in these cases. This is a histopathology of the same lesions. Squamous papilloma is commonly present in the children and sometimes linked to viral infections, and it can be in one location, usually in multiple sites. It can be unilateral or bilateral, and they appear pinkish in color, pedunculated or sessile, and they present with a peculiar picture because of fibrovascular cones present with red dots because of capillaries that are present in these cones. And it is glistening with transparent surface. Again, this can be treated also with just cryotherapy or with excision, but they tend to recur. These are examples. You can see the appearance because of this, with some blood vessels present in the center. This is a treatment by simple excision or cryotherapy. Keratoacanthoma is very similar to hyperplasia that we see. This is present in the lid. You can see the central area is amplified, but is present in the lid. There are various precancerous lesions. These have been looped into OSSN, such as dysplasia, actinic keratosis. Xeroderma pigmentosa is not uncommon here, and this is why patients are prone for tumors on the ocular surface, as well as other areas such as in the skin, as well as corneal scarring and so on. And these are some of the clinical manifestations on 10 cases that have been reported. You can see patients are usually consanguineous, and they have a tendency for carcinoma of the tongue, the conjunctiva, the presence of pterygium, corneal scarring, and sometimes they become more aggressive and invasive when they have these tumors, and they tend to also to recur more. These are the clinical manifestations. You can see in the skin picture, as well as the clinical manifestations present in the eyes. In a review of 830 published cases, survival rate for these cases is less, and there is sometimes a shield that some patients have been prescribed to wear to protect them against UV light, to prevent any further progression. A common malignant tumor, the most common one, is squamous cell carcinoma of the conjunctiva, which is now has been labeled with ocular surface squamous neoplasia, or OSSN. This came after multiple previously described tumor, CIN, which is conjunctival intraepithelial neoplasia for the cornea or the conjunctiva, and dysplasia, carcinoma in situ, and squamous cell carcinoma, and so on. So this is a better term, and this has looped all of these cases, and you will see in the literature it's mainly referred to ocular surface squamous neoplasia. The term came by Lee and Hurst in 1995, that's composed of all of these precancers as well as cancerous epithelial lesions. The incidence of squamous cell carcinoma varies from one region to another. For example, it's probably much more common where ultraviolet light is present, such as in this country or in Australia, 19 per million versus 0.3 or 0.8 to 0.4 per million in USA. The pathogenesis or risk factors for developing this is mainly ultraviolet, smoking, immunosuppression, genetics, injury, viral infection, and so on, although this has not been well established, such as human papilloma virus or HIV virus. There are terms that we should know. When we say hyperkeratosis, it means increased keratin in the skin of the conjunctiva. If there is persistent of nuclei in the keratin layer, we call it parakeratosis. And this keratosis, if you have keratinization of tender epithelial cells, individual cells. Bowen's disease used to be, but this was abandoned long time ago. So CIN was the term was used before, and this was changed. And dysplasia, atypia, which is pictures of malignant tumors. All of these pictures with the histopathology, you can see different, the polarity is different, and nuclear cytoplasm ratio has been changed. In a review in Japan of the conjunctival tumors, the most common one is CIN, or squamous cell carcinoma of the conjunctiva, or OSSSN. Then comes lymphomas, mucinous, spatial cell, and metastatic. So this is extremely important. There have been 2 studies that we conducted of squamous cell carcinoma of the conjunctiva at KKESH. One of them is composed of 100 cases, 100 eyes. Patients, I think 2 patients have bilateral squamous cell. 5 patients were bilateral, and 2 eyes were excluded. The most common symptoms that patients usually present with this tumor is mass, and the most common location is at the limbus. There are other symptoms that patients might present as well, and we will see some of the pictures. Redness, pain, itching, and so on. But mass is the most common one. In addition, it is extremely important to, there is correlations between size and invasiveness. And when we say invasive, it means invasive beyond the basement membrane. So the larger the size, the more invasive the percentage is. How about the tissues that usually involve? I mean, tissue involvement, if you have penetration or invasion, is cornea, sclera, ciliary body, and this frequency. Although the cornea tends to be more resistant, and the treatment for these 100 cases, you can see some of these cases have been even nucleated or eviscerated because some of them were invasive to the intraocular tissues and sometimes orbital tissues. A most common treatment in this review was excision with or without cryotherapy. And it is extremely important when you say excision, non-touch excisions means that you have to leave 3-4 millimeter from the involved tumor with a clear, with a normal conjunctival tissue. And also for a cryotherapy, if you want to apply cryotherapy, it is also extremely important to apply cryotherapy at the margin as well as the bed if you suspect invasion. And it has to be double freeze thaw with quick freeze and slow thaw. The recurrence is very variable from one article to another. It depends how invasive, how number of cases that have been invasive and so on, and how large is the tube. And also, more importantly, which is the most single important thing, is involvement of margins. If you submit the tissue to pathology and you found that the margins have been involved, this will tell you that the recurrence rate will be much higher. In addition, that the mode of treatment is also affecting the recurrence. This is confirmed. 50% of the cases that have involved margins have been recurred. Does it exist in patients who are young, younger than 30? It does. The youngest reported is 5 years of age. So if you have patient who is a child and they present with a lesion, don't rule it out because of age. So it can happen even with younger age group. And even in our patients, there have been some patients that has presented with younger age group. This was linked mostly with zero presence of xeroderma pigmentosa, but it can even without xeroderma pigmentosa that patients have these lesions. These are predisposing in this review of pterygium, excision, Bengicula, xeroderma pigmentosa. So the behavior of squamous cell or OSS is aggressive in our country. This is why it should be dealt with carefully and quickly. 10 of our patients were less or equal to 30 years of age, and there is a positive correlation between involved margins and recurrence. More than half of these cases were invasive, maybe because some of them they present late or our treatment was late. Sometimes we misdiagnose, we keep them to come back again to see if there is a progression. Recurrence is very variable from 5 to 55%, and 25 probably the average. And most of the recurrences happen in the first 2 years. So close follow-up is extremely important. The appearance is very has wide range of appearance: translucent, gelatinous, leukoplakic with whitish in color, papillomatous, and fungating. Fungating because if they are neglected and the tumor grow over the palpebral fissure. And we'll see. Sometimes they mimic even pterygium or thinning in the limbus, and you know that this tumor will grow inside rather than grow outside. Or present like a chronic conjunctivitis. This is a young patient who is Yemeni, who presented at age of 17 as pterygium and somewhere else, and this was removed. And then he presented a recurrence, and then he was found to have a tumor. And we'll complete his story after his slides come in this presentation. Also, they present with mass lesion, geographic corneal opacity, and we have seen sometimes tumors that present in the corneal surface with a grayish opacity. So the epithelium is thickened, and if you remove these epithelium, they are tumor cells. And this is what I was referring to. These are tumor cells. This is OSSN of the cornea. Sometimes they are solitary in the cornea, and sometimes even coming from the limbus, but creeping on over the cornea. And their excision is extremely important, and it can be even peeled. You don't have to excise the cornea. You just peel them, and they have very good cleavage plane between the epithelial or tumor cells and the Bowman's membrane. Bowman's membranes tend to be refractory for invasion for these cases. These are other presentations you can see sometimes chronic, and this is an interesting patient who presented to me with a blepharospasm in one eye, and he has a pterygium-like thinning and a lesion in the nasal part of the limbus. These are some of the cases you can see, like chronic with some masses here, finger-like, and with the papillary pattern here, so we can have different areas. George Waring, who had followed 17 cases, similar to with the finger-like corneal opacifications, and they wax and wane, and they can shrink or increase over a period. And this is the pictures that was published by his paper. You can see some of these patients, patient 17, increase and decrease in size. As I mentioned, the limbus is the most common. Other presentation that can be in the palpar or bulbar conjunctiva, fornices, or diffuse, or even isolated cornea. There have been some of the literature of denying any presence of cornea, and we have one case that has been just treated by penetrating keratoplasty in a patient who have very central squamous cell of the cornea. Again, this another patient who has diffuse bulbar as well as a limbus. that was treated during that time by excision with a cryotherapy, and this is the results after surgery without any recurrence. This is the patient I was referred as a Yemeni patient who, after excision and recurrence, the surgeon decided to remove the tumor, the recurred tumor, and put a lamellar graft. And you can see that the lamellar is a donut shaped here. And then with time, this failed. And after we tried to, do penetrating cryoplasty, we found some tumor cells between the grafted tissue and the cornea itself. And this was extended even to the iris. So this was done with a frozen section and with some iridectomy until he became just free from the tumor and recurrences later. There are reasons why you have predilections or preference for limbus because of increased mitotic activity, because of more exposure to the limbus, especially nasal and temporal, and so on. Same things applies to the pterygium. This is the case I was referring to, that you can have solitary corneal tumor that was either treated by just removing it or by doing penetrating keratoplasty without even touching the limbus. There have been even other isolated corneal that was reported in the literature. It's extremely rare, but it can happen. There are other unusual presentations, such as extension of this finger-like into the Bowman's involvement, diffuse papillomatous pigmented tumors, presence or simulating cicatricial pemphigoid, and endophotic, where the growth is inside rather than outside, as well as necrotizing scleritis and so on. These are the fungating, you can see with neglected tumors, it can even grow over, and this was squamous cell carcinoma. And this is another one that you can sometimes ignore as a post-inflammatory things. This is the patient who presented to me with some pterygium-like, and there are thinning here and there. And then this was excised with a frozen section, and the tumor was completely excised. And then he lost follow-up, and 11 months later he presented with scleral perforation, as you can see in here, with involvement of ciliary body. So presentation as perforation, this has been reported and can happen. This is the most fungating you can see by clinical as well as pathology. So this was reported before, and younger, these are some of the cases that have been reported in literature with younger than 5 years of age. The diagnosis is mainly clinical appearance. Sometimes Rose Bengal can help to delineate the tumor extension. OCT has been tried recently, as well as some smears, pap smear, cellulose, or ACTAP, there is involvement, or doubt there is involvement in the anterior chamber. And of course, biopsy is the definite diagnosis. An excisional biopsy is most important. Differential diagnosis, big list, including meningeal, pterygium, chronic conjunctivitis, because of bizarre presentations of these tumors. Is not commonly seen and should be differentiated with even rare conjunctival tumor that we'll see some of the pictures, or more aggressive tumors such as mucoepidermoid carcinoma of the conjunctiva. A treatment, the gold standard is excision with cryotherapy. Now, most people rely on medical therapy. I'll talk about it. If you have an extension, very extended tumor, and you are afraid from limbal stem, you can even shrink it by medical therapy and then excise it, or have adjunctive therapy, medical plus surgical. And this was even tried in literature. For the medical therapy, including mitomycin C, 5-FU, or interferon. These are the most commonly three medications that have been followed. And for mitomycin with a concentration 0.02 to 0.04. Literature talk about different regime. You can use it 3-4 times daily for the drops. Sometimes 1 week on, 1 week off. Some ophthalmologists use 2 weeks and then 1 week, or 3-4 weeks, and then you have another cycle repeated after 2 weeks. So it depends on the size of the tumor, which regime you follow, and how is your response, and so on. Of course, there are some complications with this, and the complications or side effects of these medications is well known. There is one study comparing all of these medications, this is one of the articles that they used topical 1% 5-FU treatment ocular surface, and it is long term. This retrospective study just showing to you that male is more commonly present versus females, and the nodular presentation is much more common. And here you can see almost more than 50%. And the recurrence rate is from 15 to 52. 75% of their cases present at the limbus as well as in older individuals. Adjuvant treatment with surgical treatment has been reported, as I mentioned, 5-FU, mitomycin, or you can try it just as a primary treatment. In this study, when they did the review for different articles, they found that 5-FU, they have very similar outcome, except the complication side effects is much less with alpha-2b interferon. Then comes with mitomycin, and then 5-FU. 5-FU has mostly the most common complications present. This is a comparison of different the three medications. The side effects are very similar. You can see conjunctival hyperemia present in both, and all of these medications. Sometimes eyelid erythema, and punctal stenosis mainly with mitomycin. And these are usually temporary. Once you stop the medications, things comes back as normal. There are other anti-VEGF medications tried as medical therapy. Aloe vera also. This has not been well tried, but these at least may be promising. For ocular surface squamous cell neoplasia, comparing previously what we used to do in surgery as well as cryotherapy, many of the surgeons now shifted, and this was a survey. In 2003, 66% of corneal specialists, they use surgery alone as primary procedure. This has dropped to 51%. So there is a tendency to use medical therapy more than surgery. If you have very extensive surgery, there are some side effects in addition that might induce limbal stem cell deficiency, scarring, symplepharon. Sometimes cryotherapy, you apply it may affect the retina and so on. Cidofovir is also another new drug that has been also mentioned in the literature. This is another paper of manifestation of xeroderma pigmentosa. You can see different clinical manifestation that might present. It extends not only to the ocular surface, but even to the lens and retina and optic nerve. For the excision, it's extremely important to have a very intact conjunctiva, at least clinically 3-4 millimeter, to make sure that the margins have not been involved that you have excised. You can delineate this clinically, or you can get it with the help of Rose-Bengal staining. If there is a suspicion for invasion, especially if you have adherence between the tumor and underlying tissues, cornea or sclera, you can do superficial keratectomy, sclerectomy in that place. And you can cover it with amniotic membrane. I don't advise to have a graft unless the things are extremely thin, because this might have a tumor as it has happened in our case. This sometimes combined with cryotherapy, and it has been shown even with the cryotherapy, combination and surgery has better outcome and less recurrence rate. This is from a study that we did, 53% versus 5% regarding involvement of surgical margins. There isn't any correlations between cell type and clinical appearance or degree of dysplasia with the recurrence, at least in some of the studies. The recurrence time is from even half a month to 2 years, so it can come as early as possible. 7 out of 9 recurred within the first 1 year. We move to the pigmented. Nevi is the most common, and this can be as a flat or elevated, well circumscribed, and sometimes different and in color. And they might not become pigmented unless at puberty. There are melanocytic proliferation